Okay, so thank you very much. We're going to primarily do an update on some of the excuse me, molecular features of soft tissue tumors, and we're going to try to focus particularly on ones that are in the skin or sometimes seen in the skin. So my only disclosure that's relevant to this talk is consultancy for Archer Diagnostics. And then I'm also going to disclose that I was in New York last weekend. I was actually at the finals of the U.S. Women's Open. And so you guys actually had a booth there. And I told them, oh, I'm speaking at Mount Sinai next weekend. So they all posed with me in the booth. So anyway, that was that. And everybody was walking by trying to figure out who's this guy in his booth that's so famous that everybody's posing with him. But yeah, I was a nobody. So anyway, it's fun to come to New York. I spent some of my time during my graduate education here at the Rockefeller. So it's a blast to be back in the city and to be in a place where I can say Happy New Year at this time of the year, and everybody knows that I mean Shana Tova, and that's not as well understood in Texas, believe it or not. So and when I told my rabbi, he was this weekend, he was saying there's a Shabbaton. Are you going to come? I said, Rabbi, I'm doing something way better than going to Shabbaton. I'm going to Mount Sinai. So anyway. With that, we'll end the Jewish shtick and move on to the lecture. So anyway, so ancillary molecular testing. So we're going to start with a little bit of an overview, and then we're going to discuss some common techniques and some pre-analytical challenges. Then we're going to move on to the ancillary molecular testing, primarily in cutaneous mesenchymal tumors. Then I'm going to give you some updates about what's going on in the emerging genetics of soft tissue tumors. So one of the really important things that can happen in a soft tissue tumor, and then these in some cases are disease defining and in some cases not, we'll talk about in a moment, are translocations. And this is where we take parts of two different chromosomes and recombine them. This breakpoints occur in two different genes, and when these refuse, they create a unique fusion gene that then creates a protein that alters the signaling pathways within the looks like somehow my slides are on a timer, which is going to make me give the talk even faster, and creates a protein that encourages oncogenic translocation. In some cases, the transformation is actually can be performed solely from having this single fusion gene there, and other times other helpers are needed. So tumors can have multiple fusion transcript types and variants, and I want to define those quickly. So a fusion type means a different way that two different genes can be recombined, so different ways to shuffle the exon. So the example here is in Ewing's, where there's lots of different ways that you can reshuffle the exons of EWSR1 and FLY1, and each of these is called a different type. A variant is a translocation between a different gene. So instead of having EWSR1, FLY1, and all its types, you can have EWSR1 ERG, and that would be a different fusion variant. Okay, so it produces the same tumor, but different genes involved. So we now know that there's lots of different these translocations that are in sarcomas, and in particular, we know that there are a set of sarcomas that have translocations that are the same, that give entirely different tumors. There was a time in the past where we used to think that a translocation was absolutely unique to a particular sarcoma type, and if you were able to demonstrate that translocation, you knew what kind of sarcoma you had. And that was really great for people that wanted to do pathology with test tubes as opposed to looking through the microscope, but it's turned out to be a little bit more complicated than that. So I'm going to show you a series of different tumors, all of which can have exactly the same translocation. So clear cell sarcoma, which is one that was spoken about just a moment ago, can have a translocation between EWSR1 and either ATF1 or CREB1. And it's a very aggressive tumor that behaves a lot like melanoma, as was discussed. Angiomatoid fibrous histiocytoma can have exactly the same fusion types and variants. This timer is going to kill me. But basically does not behave aggressively. It's more of a local recurrence type of problem. There's a newly described entity, the primary pulmonary myxoid sarcoma, same translocation. Now there's even not just getting out of the world of sarcomas and into the head and neck world, which is an uncomfortable transition for me, but I'll do the best I can. hyalinizing clear cell carcinoma of the salivary gland, and then within the oral cavity, clear cell ontogenic carcinomas. All of these the same translocations. So where we used to think that there was probably some kind of multipotent mesenchymal stem cell, the translocation occurs there, and then depending on which translocation you had, that defined the tumor. It's now probably more likely that the type of mesenchymal cell that you have it in and the environment in which that cell is may be important for the translocation. So this is kind of an emerging area in how we consider how translocations work biologically. So in addition to translocations, we can have gene mutations that can occur that are characteristic of sarcomas, such as the beta-catenin mutations in desmoid, or the GNAS1 mutations in myxomas or fibrous dysplasia, not technically sarcomas, but bone and soft tissue tumors. And then finally, the last genetic category that's fairly common are gene amplifications, particularly characteristic of the atypical lipomatous tumor and well-differentiated liposarcoma category, where the major gene that's amplified is MDM2 and sometimes also CDK4. In fact, there's a really good article coming out in the next couple of months. I think it's already online, just discussing the clinical correlates of those in liposarcomas. Then the gene amplification, we can also see MYC amplification in the post-radiation angiosarcomas, where this is sometimes helpful diagnostically. We also know that there are other mutations in the VEGF pathway that are important in angiosarcomas as well, and occur particularly in the sarcomas associated with post-radiation, in the post-radiation setting. So the types of sarcomas that have the types of events that we talked about, translocations, amplifications, tend to have fairly simple karyotypes. There are also ones that have much more complex karyotypes with lots of chromosomal transitions. These are usually associated with P53 or RB mutations, or more recently, a number of groups have been starting to demonstrate ATRX mutations, which result in telomere dysfunction. And so these are just some examples of some of these complex karyotype sarcomas. So these are the ones that are not associated, as far as we know, with translocations. So moving on to some common techniques and some of the pre-analytical problems with these. So if we think of an overview about how we do molecular testing, we've got cytogenetics with traditional karyotypes, we've got fluorescence In-Situ hybridization, and we've got polymerase chain reaction. So classical cytogenetics can work really well to demonstrate translocations. You need fresh tissue. You need good people with, that can grow this and interpret these. Sometimes the karyotypes can be complex, but we have different ways of doing chromosomal painting that can be extremely helpful in sorting that out, such as with spectral karyotyping. Fluorescence In-Situ hybridization. Here we're probing a particular gene locus and then looking for evidence that this locus is rearranged. So it'll tell you that one gene is rearranged, but it doesn't tell you what the partner is. And so if you have a differential diagnosis that includes rearrangements of the same gene, this test doesn't actually distinguish between those. On the other hand, it's an easy way to demonstrate that there is a gene rearrangement in anything, in this particular case, that has a rearrangement of EWSR1, which, if you'll remember the graph that I showed you, was actually seen in a variety of different neoplasms. So this is a fairly widely used technique. PCR-based detection, very sensitive. You need to know what the specific fusion is that you're looking for, and you need to know what variant you're looking for and what type you're looking for in order to design a PCR reaction that will pick that up. And for some of the complicated ones like Ewing's, this can require multiple primer sets in order to cover all the different types, and so you just need to be aware of that with this approach. So some of the common pre-analytical problems when we try to use these methodologies with tumors is sometimes with biopsies we have really scant tissue. Sometimes we have a lot of necrosis. Abundant normal tissue can be a problem with some of the techniques. Blood in the specimen, heavy pigmentation, either melanin or hemosiderin. Really old tissue that's formalin fixed is sometimes challenging. RT-PCR is more sensitive to this than FISH. And then And then decalcification is really bad for nucleic acids, particularly for RNA, and so decalcified specimens, it's a real problem to apply RT-PCR techniques to these. So things are starting to emerge with different approaches to these with multiplexed fusion assays. These are essentially focused RNA-seq, an application of next-generation sequencing. So now we can have theoretically single assays that can detect multiple to many different translocations. We don't need to know both partners. We really only need to know the breakpoints for one of these. And then we can use this to detect multiple both types and variants. And this would, theoretically, these types of approaches would decrease the number of false negatives. So this really maximizes the use of limited material that you can see in one assay. So this is an example of such an assay here where the breakpoints are targeted on the genes that are in the upper left-hand corner of the slide. And then regardless of what these are translocated with, the non-specific primer in the opposite direction will help you pick that up. So theoretically, you can pick up in a single assay many different specific translocations associated with sarcomas. So this is an emerging approach that I think will become more and more widely used in the field. So this is just a summary. I think you guys all got the lectures. It's kind of a summary of the pluses and minuses for each of the techniques. I don't think I'm going to go over that again. It's in your in the copy of the lecture there. So let's look at the role of some of these types of testing in some relatively common cutaneous mesenchymal tumors. Well, some common and maybe one not so common one. So we all know that mesenchymal tumors can be challenging. There's lots of different types, probably over 100 histologic types, not including the bone tumors, each with varying clinical phenotypes and behavior. Unfortunately, we can have some confusion between benign and malignant forms, and then unfortunately, there's still a class of tumors that are really challenging to classify and are essentially unclassifiable. Although that's, in the grand scheme of things, it's a relatively small subset. So why do you want to use molecular diagnostics in mesenchymal tumors? Well, they can help you confirm your histologic expression, particularly in small biopsies, which make the field more challenging. You can distinguish between similar appearing tumors, and you can also confirm tumors that have unusual clinical, histological, or immunohistochemical features, and we'll talk about some examples of those. This can also be important between maybe such testing can help you distinguish between a tumor that would be benign versus a more malignant behaving tumor. So the examples we'll go through quickly here will be DFSP, clear cell sarcoma, and cutaneous Ewing sarcoma. So DFSP normally is fairly straightforward to diagnose, but there are some more challenging variants. There can be some very myxoid looking ones, and then there are small biopsies. Cellular dermatofibromas can sometimes express CD34. This can be a problem, and there are other potential mimics as well. Here's an example of a classic DFSP that most people with CD34 are not going to have a problem diagnosing, so a molecular approach here probably would not be necessary. Of course, you know that the detection of these is a translocation between COL1A1 and PDGF beta that essentially causes an overproduction of PDGF beta, and then the COL portion or the collagen portion is actually cut off, giving you wild type ligand. You can detect this both by RT-PCR and by FISH as well. Both approaches are fairly straightforward. The FISH is somewhat complicated because of some of the structural features of the rearrangement. But the PCR is also really complicated because you can have about 47 different breakpoints in the COL1A1 gene, so you have to design primers to cover all of those. So here's an example of a DFSP that's gone on to fibrosarcomatous differentiation. If it's completely overgrown, this can create some problems to recognize this. These, of course, as you know, often will lose their CD34 reactivity, although not always, in the fibrosarcomatous area, as shown here. And then we can have some unusual forms of DFSP, such as the giant cell fibroblastoma that's more common in the pediatric population. This can sometimes be a challenge to recognize. And then you can have, in rare cases, a relatively sarcomatous transformation of the cases that are a challenge to recognize as well. These are usually in recurrent tumors where the patient may have had the case as a child, and then they recur later in adulthood. And then, of course, sometimes the confirmation of this can be helpful because while most DFSPs are clearly a straightforward surgical problem, at times there are reasons where you may want to use systemic therapy, and these respond to tyrosine kinase inhibitors. And I don't think that the treatment of DFSPs by tyrosine kinase inhibitors is FDA approved, and so I need to now say that I'm talking about a non-FDA approved treatment for a tumor. So although I didn't recommend it, I just said that it happens. Don't know where I got those slides from. Anyway, clear cell sarcoma, some of the problems that we can have with these can be difficult to exclude from melanoma, which shouldn't surprise you because you just saw a lecture showing that they show expression profiles that are very, very similar to melanoma. But still, it's important to exclude these from melanoma because the staging principles and nowadays the treatment for these are very, very different. So here's an example. I'll tell you that one of these is a melanoma and one of these is a clear cell sarcoma. So one's a female age 41 with a right neck mass, and one's a female age 63, which is a little old for clear cell, but maybe the location is better because they're usually in the extremities. So which is which? So not going to torture you. The one on the left is negative for EWSR1 rearrangement. The one on the right was positive, and so the one on the right, even though it's an older patient, is in fact clear cell sarcoma. So here's an interesting case here that was on our service a while back. This was a 65-year-old female who had an axillary lymph node metastasis. Classic setting in terms of looking at this, an S100 positive neoplasm with a little bit of melanocytic differentiation. For a melanoma of unknown primary. However, this was actually looked at and shown to have an EWSR1 rearrangement, and then later by RT-PCR we showed that it actually had a EWSR1 CREB1, which is the less common fusion variant in this case. So clear cell sarcoma of unknown primary in a lymph node is kind of unusual. So we went back and looked more closely at the patient, and they had this little bump on the palm of their hand. And you can see here, you're starting to see some of the more classic histologic features with these wreath-like giant cells within the tumor. And so this was actually a cutaneous clear cell sarcoma that presented with metastasis to the axilla. So cutaneous Ewing sarcoma, this is an uncommon setting for Ewings. It can be confused with lots of different more common tumors within the skin. But we do see Ewings within the skin. It's less aggressive than the deeper appearing Ewing's tumors. I hope they're not coming for me. So this was an 11-year-old with an ulcerated right foot mass, and they were positive for an EWSR1 Fly1 rearrangement. And just another case here showing the relatively classic Olympic ring type CD99 reactivity. But unfortunately, we don't always get that in Ewing. So here's a case of Ewing's that was confirmed as well. They often have a little bit of low molecular weight keratin scattered within them. This one, the nuclei look a little bit more aggressive, and they were actually S100 positive. So if I did FISH on this for EWSR1 and I saw S100 positivity and I didn't know the history, I'd probably head toward clear cell sarcoma, but I'd be headed the wrong way. It's very unusual for these to have. I'm showing you exceptions. Most cases of Ewing's do not have S100 reactivity. But here's another case here. I've got Olympic ring, CD99 reactivity in a small cell neoplasm, but this is a small cell variant of synovial sarcoma. So sometimes the histologic appearance and the immunohistochemistry can be tricky. So this is a place where it's useful to do molecular confirmation within such cases. So again, here's the relatively classic pattern that we really like to see, the one that we all work really hard to take pictures of whenever we write textbooks and review papers on Ewing's and say Olympic ring type reactivity of CD99 is characteristic. Here's another series of molecularly confirmed Ewing's from our service, and maybe our immunohistochemistry is really bad, but sometimes it looks like this. Is that Olympic rings? I don't know. It's kind of like not the greatest Olympics, but depends on what you like, I guess. But cases like this, sometimes it's a challenge that our tools with immunohistochemistry don't show don't always show the classic findings. So employing these techniques in this type of setting is important. So I've showed you now that we can use karyotypes where we're looking at metaphase chromosomes. We can use FISH where we're looking at interphase chromosomes. Tough to do this from DNA because of the massive size of the introns relative to the exons. But we can do this by RT-PCR with RNA, which where we have the introns sliced out. And then there are a few cases where immunohistochemistry can be helpful to show evidence, possible evidence of the fusion gene, although not always incredibly specific. All right, so let's quickly do some updates for what's kind of we're going to first discuss what's kind of intermediately new, and then what's super new in cutaneous soft tissue. So here's some of the new molecular alterations that have been discovered just within the 5 years in some tumors, and we'll go through quickly some examples of these. So nodular fasciitis. I mean, who would have thought? Many of us, would have suggested that this was a reactive lesion potentially, although there was always the data that it was clonal and this, but it self-resolves. Turns out that just another example of a case from the ear and then a case from the skin, showing that these more superficially located cases, that it actually has a translocation between MYH9 and USP6, and so it's a self-resolving neoplasm with a translocation. Really interesting biology there. Epithelioid hemangioendothelioma, not as commonly seen in the skin. But can be seen in superficial biopsies sometimes when it involves the soft tissues, and also has a translocation now, which can be helpful diagnostically. This WWTR1 CAMTA1 gene fusion, and just some of the details about the fusion. There's several different types that can be seen, and then here's an example of a case with RT-PCR. And then turns out that you can have a completely different fusion variant within epithelioid hemangioendothelioma involving YAP1 and TFE3. And they have slightly different morphology, but most people still consider them to be within the same spectrum. So a relatively new tumor and or newly named tumor within the last few years, but this epithelioid sarcoma-like hemangioendothelioma, or sorry for the misspelling down below, or pseudomyogenic hemangioendothelioma. Locally aggressive, tend to be multifocal. They have a very odd immunohistochemical spectrum where they'll have both endothelial markers and keratins at the same time. Just another case here, and again showing this relatively bland spindle cell appearance, and then the co-expression of CD31 and keratin. And these have translocations between SERPINE1 and FOSB. So ossifying fibromyxoid tumor, not so common in the skin, but have a relatively newly described translocation, so I slotted them into the lecture anyway. So characteristically, they have this bone around the outside. Sometimes they can be, the more superficial ones sometimes actually lack the bony component, and then you have a non-ossifying, ossifying fibromyxoid tumor. They have these very small nuclei in some of their forms that are S100 positive, so they can create some difficulty potentially between a melanocytic tumor. And these also translocation here as well, and with PHF1 and EP400 is the most common, but there's a variety of other fusion variants as well. Solitary fibrous tumor, now known to have translocations between NAB2 and STAT6, and just some of the structure of the fusion gene here. This one was really challenging to pick up because it's literally an inversion within a chromosome, so it never would have been picked up by. It was only picked up by next generation sequencing. It actually can't be seen readily with cytogenetics. And now it even looks like there may be some differences in terms of the fusion types with the histology and clinical pathologic features, although I think this study probably needs some confirmation, but it's an interesting initial study. So then some super recent stuff, epithelioid fibrous histiocytoma. Who would have thought actually have ALK overexpression, and this is associated with an ALK rearrangement. So these are actually ALK rearranged. Could create a differential diagnosis, maybe with anaplastic large cell lymphoma, but probably not. But just be aware that you can see this, and these do have those translocations. And then another one that many would have suggested various forms of it might have been reactive, benign fibrous histiocytoma, just the classic cases, have protein kinase C isoform fusions causing overexpression of PKC that seems to drive their development. So this kind of confirms their neoplastic nature. So our take-home messages in my last 25 seconds. Take-home messages are, so molecular testing can certainly be helpful in cutaneous soft tissue tumors. And we have these new discoveries that I try to go through quickly at the end, not so that you'll remember them, but just to remind you that they ever existed. These can really further our understanding, not just of the biology, but they can also aid in diagnosis and hopefully eventually in treatment. And then what's really important with this is, even though I spend a lot of time in the research lab and the molecular lab, that molecular results still can't take the place of a really sound clinical radiologic and histologic and immunohistochemical examination of the tumor in order to come to the correct diagnosis. So we'll also have jobs at the microscope, I think, for a long time to come. So thank you very much.